So today we are going to have a little discussion about the use of ultrasound in an ICU setting. As we all know, ultrasound is now coming up fast for diagnosing and for kind of monitoring tool in all the hospitals, and especially in an ICU where you need to make quick decisions and need to monitor the patient and implement your decisions. So, how ultrasound can be used in an ICU? We can do an echo in the form of focused examination, not the detailed echo like a cardiologist can do, but a short one where it is useful for monitoring and diagnosing the patient. As a ultrasound of chest, in abdominal ultrasound as fast, so that you can identify the bleeding and the hemoperitoneum fast and do something about it. And last and not the least is the intravascular cannulation, which is very important. It is coming up very fast now because no patient likes to be pricked uh, multiple times if you're doing it as a without ultrasound. Plus, the number of complications which happen with the use of ultrasound are markedly less if you do it blindly. So let's see how we can use this ultrasound as a modality in our ICUs. First is echo. Now, echo, as we all know, has always been a domain of a cardiologist, but it is replacing cardiology in ICUs very rapidly, as more and more intensivists are now showing interest in doing echos themselves, because cardiology is not always uh, available 24/7 in smaller setups. Plus, the need not to have that detailed echo, especially in patients when you have to have a diagnosis immediately, is uh, very high. So all the intensivists now very fastly coming up with a focused echo scan, which can be used especially in patients where you require hemodynamic monitoring. So what is hemodynamic monitoring? Hemodynamic monitoring means when the patient's hemodynamics, that means his blood pressure, heart rate, respiratory rate, everything is varying, and you need to make a decision. Like you have a patient of cardiac failure or a patient of say renal failure who is on dialysis and all swollen up, or a patient of CLD. Now his blood pressures are low. You don't know, looking at him you are not able to decide whether to give him fluid or not to give him fluid. So here, what hemodynamic monitoring is important. You need to assess the patient whether he require fluids or doesn't require fluid. So here you can make a use of echo. Now it could be only purely for monitoring purpose, or it can be used as a therapeutic tool also for removing some fluid or to insert drains or anything. So what does echo help us with? It helps us in assessing the cardiac output, in assessing the fluid responsiveness. Like you give some fluid and you want to see if whether by giving the fluid your patient is responding or not. So you can, before assessing it clinically, you can look at the echo and see directly his cardiac chambers, his contractility, his IVC, and assess whether your patient is fluid responsive or not. You can assess cardiac contractility with the echo, recognize other medical emergencies like your patient is having cardiac tamponade or acute cor pulmonale, like in cases of pulmonary embolism. So here, echo plays a very important role. How? We'll see it further. Okay. So it helps us. No, next, previous slide only, please. It is required for quick diagnosis and management. Now, as is with any other modality, it has certain challenges. Now, what are the challenges? In patients who are mechanically ventilated and on high inotropic support, the hemodynamics are all altered. So you do not expect the echo findings to be same as that of a normal patient. So here what lies the challenge? You have to assess because your patient may be very on very high inotrope support, or he may be mechanical ventilated, like we have all seen it in COVID-19, where people went into ARDS, so they had high PEEP requirement. So all these factors affect what you find in echo, which may not be pathological. So we'll see in further slides that how these challenges can be overcome to a certain extent. Now, there are certain illnesses that can interfere with echo, like patients who have hyperinflated lungs, patients who have surgical incision and drains. You may not be able to make a proper window to assess or to do an echo, or patient have multiple dressings. He has inadequate exposure or positioning, which can all alter your echo findings. Next, please. Now, we all know the sepsis guidelines. So there it is a gold therapy. It is required to give fluids. So how can you give that? It is through goal directed therapy. And how you can assess that? Through echo. Now, echo is also required for detailed valvular function, any congenital abnormalities in intracardiac shunt, or in the estimation of pulmonary pressure, which can be done by an echo assistant with the help of a cardiologist. Now, this is only when you can do it in echo rooms or with the help of a cardiologist. But rapid cardiac assessment in the form of some do raise, some fade, some focus, anything, it can be done systematically in the ICU, and then it has to be correlated with the patient's clinical status, because everything what you are doing is just a diagnosis, and it has to be correlated clinically with the patient. All right, next please. Now, when you want to do assessments and you do assessment, after that, how do you know that whether your assessment is complete or not? It's only complete if you are able to answer the question for which you were trying to do the echo, like your heart function, whether it's right side or left side, if there is evidence of pericardial effusion or tamponade, and last, what is the volume status of the patient. So these are the basic 4 points because of which we want to do echoes in ICU. Now, this is just, please pay attention to this chart. So this is a rush examination, which whose short form is high map, which means you assess heart, IVC, Morrison's pouch or the Morrison's fast abdominal ultrasound, aorta, and the rule out pneumothorax. Now, how do you do this? So you divide everything, please, previous slide only, into 3 parts. Pump, which means the heart. So you scan the heart. Then you scan the tank, which means the vessels which have large amount of blood and is stored in that, like IVC. Then is the pipes, which means the basic blood vessels where supplies blood to from the take out from the heart and supply it to the body, like aorta, or smaller veins like abdominal inferior vena cava, the inferior hepatic part, or the large vessels like popliteal veins, these femoral veins. Okay, so you have to divide your area of interest into pump, tank, and pipes. So different type, we all know there are different types of shocks: hypovolemic shock, cardiogenic shock, obstructive shock, and distributive shock, which is the septic shock. So all these shocks are different. So the findings also in echo are different. Hypovolemic shock, as it already the name suggests, hypovolemia, it means you have less volume. So anything which has less volume will be small. So when you do an echo, you will see a hypercontractile heart, because it is trying to compensate your hypovolemia by increasing it heart rate. So contractility will be good, but the chamber size will be small. Okay. Along with that, your tank will be empty because there is no filling. So IVC will be flat. The internal jugular veins, they will be small. There can be evidence of fluid in the peritoneal cavity or pleural cavity, which may suggest that the patient is oozing from here, like hemoperitoneum or blood in the pleural cavity. All right. Or you may have an abdominal aneurysm or an aortic dissection, which is bleeding. Now, in cardiogenic shock, the heart will be, as the name suggests, it is because of the basically because of the cardiac abnormality. So the heart contractility will be hampered, and because of that, the chambers will be dilated. So you will get hypocontractile heart and a dilated heart. So when the heart is dilated, the back pressure changes will cause the IVC and jugular venous distension. Along with that, if it's left-sided, you will also get pulmonary edema, and you can get pleural fluid or peritoneal fluid because of the back pressure changes. All right. All the major vessels will be normal because it is primarily the abnormality of the heart. Now, obstructive shock, like occurs in pulmonary embolism. Okay. So here, it is not because of, there is no abnormality as such of the heart. It is only because it is not getting enough supply. So the contractility, that is the pumping, will be normal. There will be evidence of pericardial effusion or cardiac tamponade. There will be evidence of RV strain or a cardiac thrombus, which may or may not be evident on echo, because only if it's a big thrombus, you'll be able to appreciate it. A small thrombus cannot be appreciated on echo. It totally depends on observer, uh, how he sees it and what is his technique. So because of the RV strain, there will be back pressure changes. So like in cardiogenic shock, the IVC will be distended, the GVP will be distended, or if the cause is pneumothorax, you can appreciate lung sliding, which is absent in on ultrasound. Along with that, you may or may not appreciate a thrombus in the long veins, which will point towards DVT, and that is what has caused pulmonary embolism. All right. In distributive shock, which is because of the sepsis, there will be, again, it is not primarily a dysfunction of heart. So heart will, contractility will be good. It will be a hypercontractile heart, especially in early sepsis. But as sepsis progresses, it starts affecting all the other organs also. So it may lead to myocarditis and may lead to hypocontractility of the heart. So whenever there is hypercontractility, it will show you normal or small IVC. So initially your patient will be fluid responsive, but as the contractility decreases, your patient will be less and less fluid responsive and will show you a distended IVC. So you can also see the source of sepsis if it is in peritoneal fluid, or you may find it in pleural fluid. This is one of the examples. Not every time you will see all this. Okay. But the other long veins and arteries will be normal. So except for cardiogenic shock, in all other shocks, the contractility will not be affected. It will be only affected in cardiogenic shock, where you will find contractility will be decreased and the heart will be dilated. Okay.